made.
Hello, good evening. We're just getting started here. I'm going to load a test and then I will send you guys a code for the group. Okay, can you guys hear me? All right, good evening. Okay, good. So, all right, I'll wait for people to roll in a little bit, maybe 3 more minutes. Oh, good, good. Thank you, Sergio. All right. So just while we're waiting, I'm curious, how many of you have taken an NBME? How many of you have, um, started your, you know, reading first aid or getting started on questions in QBanks? Just so I get a feel for how far we are along. Just started. Okay, cool. Cool, cool, cool. And what year of med school are you guys in? Or if you guys have graduated, let me know. Grad. Oh, okay, okay. Great, great. Yeah, I've been tutoring a long time. I've been tutoring about 5 years, give or take. Fourth month of preparation, not MBME. U World, yeah. Radiology resident. Oh wow, not good. Yeah, yeah. I think the NBME. I'm going to talk a little bit about that before we get started about the NBME scores because they're very intimidating until they're not. Um, and That's one of my favorite pieces of information to share with people when they're getting started because it's reassuring. That's what people want and need, I think, in the beginning for sure. Um, Welcome. Wow, we're getting a lot of people. So here we are. It's 2:05, and I'm going to be clicking a lot of admits here. Oh, Leslie's here. Okay, cool. I'm going to send the link to just one person who asked me to send them directly, and then we'll get started. Uh, Explain the format as well. Um, okay, I'm still admitting people. Ordinarily, I'd have my assistant's a little sick today, so uh, we have a lot of people. This is great. This is awesome. Um, so let me get started. The way that we will structure basically the next 2 hours is to go through real USMLE Step 1 questions using a website called MedBullets, which is a free website. It has plenty of questions for you. It isn't top tier, QBank, but it is really good for initiating students to how they're adequate questions. They're definitely fair game on the exam, and they're written by people who have taken the exam before. I know the owners of MedBullets, and they're good people, and so we will be running through some of those questions. Um, and How I like to structure it is people are chosen through the group to field a question, to try to read it out loud to people and try to like answer the question. I know it's kind of intimidating at first, but basically kind of create a weekly experience where people feel like they'll have to perform, like they'll have to come to these meetings, and prepare for these meetings and hope that they answer correctly. But it's not about correctness. It's not about being totally prepared on day one. It's about getting used to answering the questions, thinking about the way that the test is structured, and getting some test taking ability as well as content covered in 2 hours a week, and get some kind of experience answering USMLE questions the way that they're designed, because they are designed to take you longer than 90 seconds if you don't read them correctly in the right kind of format. So I'm going to share my screen here. Let me set it up so that I'm sharing the right window. And what the way that we'll do this is I'm using MedBullets, and I'm just going to put the code in and we'll get started. So grab the code. Okay. Learning mode. And what will happen is the people who participate or opt to participate will get a code at the end to review all the questions that are in this block. Meanwhile, I'm going to have a video of the questions that we cover, and it'll be perfectly adequate for you to review it that way. It's just a little added incentive to participate, because it is kind of intimidating at first. But I promise I'm going to help you along and make sure that you feel good about participating. Let me just grab this code real quick because it reset. So enter code and start test. Okay. So now I'll show you what I'm talking about. All right. So can I get a thumbs up if you guys see this? Okay. And I'll just take the group chat. Okay, you guys are good? Okay, cool. So does anyone want to volunteer and answer a question here? Or do you want me to do the first one? All right. So feel free to turn on your mic and just kind of say hello, and we can get started. Anybody who wants to try one? I promise you, you'll look good by the end of this. I'm gonna make sure of it. I think it's more engaging if we answer some questions here, and it's kind of the vehicle through which I'm kind of teaching the 2 hours. Anybody want to participate? I can call on some people. It's a little bit awkward to volunteer yourself. I know. Um, Sergio, would you do the honors? Here I'll do the okay. I'm on a call. Okay, no problem, no problem. So why don't I do this one for you guys, and I'll just kind of explain how it's going here. So the format of these exams are usually a little bit longer questions. Some of them can be this short. Um, the People are still rolling in. So so ordinarily, obviously, it's structured like a presentation of a real patient, as presented by a um, physician to their to or a resident physician to their attending. And so if you took a history from a patient, you would start with the age, the sex of the patient. You'd get to the point first. with a summary about what is the context of the visit. No worries, no worries, Sergio. It's totally fine. Um, and and then you would get to some physical exam findings. You talk about lab values that were pertinent to the case, and then you would talk about um, some of the further history, family history, and things like that, and pertinent details. Tell a story about the patient. The questions are structured that way for the USMLE exam. So one of the things that people do is when they to save time on the exam, because time is really of the essence on these exams, is to read the question sentence, which is the question that ends in a question mark, to read that first and then read the answer choices very quickly. Just categorize what kind of question is this. So you read this and you see that it says fingernail pitting. I already know that refers to psoriatic arthritis. Arthralgias would be an arthritis of any kind. That's painful joints. Wheezing would be some kind of respiratory illness. Could be asthma, could be, lots of things cause wheezing, up to and including pulmonary effusions can cause wheezing from the cytokine release, and early DVTs can lead to PEs, can lead to wheezing. I mean, lots of things can lead to wheezing. So I'm not sure what that answer choice is. Gluten hypersensitivity would be celiac disease, and cyanosis. Lots of things can cause cyanosis. So the question is, what thing that causes cyanosis in a 2-year-old, for example, if you were trying to categorize this wrong answer choice or correct answer choice, would lead to a rash like this. You look at the rash and it's not demarcated. It's very red. There's some white spots here. There doesn't appear to be any crusting. It's not nummular, which is to say it's not. I mean, you could say that it could be nummular, but it's not. It's not in a ring shape. So you're not worried about tinea corporis, which is a ringworm, right? And so you're thinking about this answer choice. You're thinking 2-year-old male. Patient develops a skin presentation similar to A on his cheeks and chin. So that's the location. And exposed to a certain food product. So this is a response to food, right? So cyanosis in response to food is really, that would be an interesting response in a 2-year-old. Usually cyanosis from response to food would be something on the order of transesophageal, so tracheoesophageal fistula, something like that, where you eat and the food gets into your bronchus, into your lungs, and causes aspiration. So that would cause cyanosis from respiratory distress, from blockage of the respiratory system. So that's usually in a younger child. That's not going to be a 2-year-old, right? So gluten hypersensitivity could certainly cause you to have a rash, but what kind of rash does it cause? Does anybody know what kind of rash celiac causes? I'll just look at the chat here. Yeah, gluten
No.
Yeah, are you there? Yeah, I can hear you. So what kind of rash would celiac disease cause? Do you guys know?
I don't have any idea. I'm sorry.
That's okay. So
dermatitis, herpetiformis.
exactly. And so why is it called herpetiformis? That's great. Thank you for whoever said that. I'm not able to see the videos and see who's speaking. So let me know who you are if you like. But that's exactly correct. So gluten hypersensitivity is celiac disease, is dermatitis herpetiformis, which looks like herpes, but is in response to gliadin, which is the antigen in gluten that causes you to have a skin reaction called herpetiformis. And wheezing, now I'm not exactly sure what would cause wheezing in this situation. A food allergy that causes wheezing might be an anaphylactic reaction. You could have someone who is wheezing as a result of anaphylaxis from an allergy. That's a severe reaction. That could be something like peanuts. So do you think that this is urticaria, some kind of like, they don't mention itching, but does this look like urticaria, otherwise known as hives? Does anybody know? What about this does or doesn't look like hives to you? What do you think? So I don't think it looks like hives at all. I think hives usually looks like wheels. So they're usually kind of semicircular, not semicircular like half a circle, but looking similar to a circle. They're usually raised. Yeah, it doesn't, right? Carolina, that's right. I think this is probably not urticaria. Urticaria, is a skin reaction that you can have to, to medications and to foods, certainly. Yeah, it reminds me of psoriasis is right. I think you're right, Romulo. I hope I'm pronouncing these names correctly. Sorry if I'm not. Trying. But I think you're right. Reminds me of psoriasis. So, um, um, I don't know that this is just so there's erythrotelangiectatic psoriasis. There's nummular psoriasis. There's plaque psoriasis, which is the most common, um, and there's guttate psoriasis. But I'm not sure exactly. This could be erythrotelangiectatic. But again, that's a very, very itchy rash. They haven't mentioned any itching, which is confusing, but also this is like a two-sentence question. So why don't we choose? Why don't we get a few answer choices? What do people think the answers choices would be here? Fingernail pitting, that would be like psoriatic arthritis. So that would be psoriasis related. So what do we think the answer choice is here? I like to get things wrong and talk about it. So because I think the best questions are the questions that we don't know the answer to yet, and we go over. So let's check. So atopic dermatitis is a great answer. Atopic dermatitis is a type of skin reaction that has to do. So one of the things about atopic dermatitis that will be true, um, as opposed to like contact dermatitis, is you won't have that linear. Um, you won't necessarily have that linear formation. So which of these answer choices do you think, one, two, three, four, or five, do you like? Because I think atopic dermatitis, you could get it, but it's less common to get it from a food that you had exposure to so far as exposure to um, a lot of people get contact dermatitis, chronic contact dermatitis from washing their hands too much. They get contact dermatitis um, from a fabric that they don't like. Yes, IgA mediated can be. So does anybody want to go out on a limb and give me a number? I'm going to put you guys on the spot and say we got 14 people. Somebody can give me a guess. It's okay to be wrong. So we got four. We got to vote for four. Gluten hypersensitivity. That's the herpetiformis. So three. We got wheezing. That could be anaphylaxis. We got a four again. All right. I like it. All right. 4-2. Okay. So we got more fours than we got threes. So let's go for four. And I just ruled four out. All right. Submit response. Aha. So somebody did say three. So Mateus is correct. I hope I'm saying that correct. So Mateus, do you want to now that you got it right, do you want to come on the mic and tell us how you knew? This is the atopic triad. Do you guys know what this atopic triad is sometimes called? It has a eponymous name. This is the Sumter triad. Have you guys heard of that? Oh, that's okay. If you're on, he's on call, so that's okay. Um, yeah, you can write a little bit. Don't feel beholden to write it out if you don't want to. We got the explanation here, but I appreciate your answer because this is also called this. They call it the atopic triad here because they're trying to get rid of eponymous names. But you might have heard of this as the Sumter triad, which is to say, if you have asthma and you have a rash that looks like eczema. By the way, eczema looks a lot like dermatitis herpetiformis, so it is very easy to confuse the two. I think one of the things that will separate this from dermatitis herpetiformis is it's not as vesicular as you would want it to be. So vesicular is definitely a word that they'll use to describe it. Vesicular is a word they'll use to describe herpes viruses, HSV and zoster and shingles, especially. But this is not as vesicular, and vesicles are kind of raised, kind of large papules full of. They have like liquid inside of them, and so tell me about lupus if you're thinking about lupus here, because I'm not following the. I understand that this could be. It does kind of resemble the rash does look like a wolf bite. They call it for lupus, right? The wolf bite rash. So this is really just the mainstay of this question is understanding that you can have allergic rhinitis, which they did not give you in the question stem. Um, but it started on the chin and the cheeks, which is a sign because this is a commonly occurs on the face. Um, you have eczema, which is itchy. They should have said probably. Um, so yeah, so yeah, so you're saying this is a type 4 hypersensitivity. So type 4 would be contact dermatitis would be type 4. I think with atopy, um, asthma is in two phases, and I think atopy is similar in that way. Yeah, type 1. Um, so you have histamine release, right? So you have the coupling of the IgE, and then you have a later kind of leukotriene mediated response in two phases. Um, so how do you guys feel about that question? I think it's good to identify the diagnostic criteria, kind of look at a lot of eczema pictures and get a feel for what that rash will look like, separate it from the dermatitis herpetiformis. And then unfortunately they didn't give us this triad. So I think as signs that this question would be correct for choosing wheezing, I think it's a spot diagnosis, which is to say, if you see the rash, you should diagnose the rash. Yeah, yeah. I think this is the problem with med bullets is not that it's easier or harder, although I think you're right that it is easier. I think it's also unforgiving in that there's not enough. There's not a whole hell of a lot of information here, and there's a lot of very extraneous questions. So they're good. They're usually correct, but they're usually they can be hard for the fact that the author is not their job is not to write questions all day. Their job is usually to be a student, and they're writing these questions as a side hustle with a very good step score. So that's one of the drawbacks of med bullets, but it is free. If we used UWorld, unfortunately, this would be like copyrighted material. But when I do I do personal tutoring. If you guys want tutoring, and I use UWorld for that. I use Ambos for that. And I'm a big fan of On King the deck, and so I sometimes we use that. But does anybody want to read this out loud and try to answer it like a real question? I know that it's a lot to ask. It's a lot of but it can kind of get you in the framework, and then I can get a sense of like how you think about the question, what you're thinking about as you answer it, what order that you read it, how quickly you're thinking about the diagnosis, or whether you're thinking about the correct line of reasoning. So it helps us kind of evaluate ourselves and how we're taking the exam to see someone answer the questions in real time. But does anybody feel comfortable doing that? Let me know in the chat. It's okay if you don't, or you can just turn off your mic and have at it. All right, all right. Let's keep going. Let's keep going. So let's see here. So an 8-year-old boy is brought to the emergency department with severe dyspnea, fatigue, and vomiting. So his mother. So let's take this apart. The first sentence, you really want to make sure that you're thinking clearly about, like, you want to have a picture in your mind before you move on from the first sentence. You do not want um, you want to have a picture in your mind of the patient before you move on. So 8-year-old boy, emergency department. So they're concerned. The patients present with concern, that is above the out. They're not setting an appointment. They're going to the emergency room. Severe dyspnea, fatigue, and vomiting. Okay, very sick. So then I read the question sentence. It says, which of the following would you expect? And it has a bunch of answer choices that are clearly acid-base questions, right? So I'm seeing some answers already. People are saying 3. So we'll see here. His that would correspond to decrease in serum potassium. So his mother reports that he has been lethargic for the last several days with an increase in urine output. She thinks he may even be losing weight despite eating, drinking more than normal for the last couple weeks. Laboratory results are notable for glucose of 440. So what is a normal range for glucose, you guys? When they talk about glucose, by the way, what kind of test are they talking about the patient having taken to receive a 440? What are we saying? Are we saying this is an oral glucose tolerance test? Or is this a fasting blood glucose? Or is this a finger stick? Or is this a dipstick? Are we just guessing their glucose? What is the 440? So I see jejunum 126. 126. Jejunum 126. Yeah, 126 is the number that you would expect a fasting blood glucose to be, right? And you're saying hemoglobin 6.5. Hemoglobin 6.5. Yeah.
This level of glucose, wouldn't he be on coma?
You're saying if they had above 126?
No, 440.
Oh, it's extraordinarily high. It's extremely high, right? So one of the thresholds is the fasting blood glucose being above 126 is diagnostic for diabetes mellitus, right? And then having a blood glucose above 300 means that you're all of a sudden have so much concentrated glucose in your serum that you are now able to urinate glucose because the proximal convoluted tubule is unable to withstand that level of concentration. At those concentrations, you have non-enzymatic glycosylation of your microvasculature. You have damage to your, to your microvasculature and your nerves. You're going to have, kidney damage, potential glomerular damage from the non-enzymatic glycosylation. So this is a very seriously high level of glucose. And what's more is to notice that this is a young boy, right? This is an 8-year-old. So this is probably type 1. It's probably not type 2 because that would be like adult onset diabetes. So that's another thing to notice. And look at the potassium. It's raised above. What is the upper limit of potassium? It's usually, 5.5. Different lab values will tell you different things, but it's usually 3.5 to 5.5 or 5.2 sometimes. pH 7.14 is that extraordinarily low, or do you guys think that that's like just slightly low pH?
Really low.
Really low, exactly. Who's talking here, by the way?
Homlu.
All right, nice to meet you, man. Thank you for talking to me. I feel like I'm talking to myself a little bit sometimes. So welcome. So pH of 714 is super low. He's right. It's super acidotic. And so this is, how could we categorize this person with glucose at 440, high potassium, and a pH of 7.14 without even looking at bicarb? How would we think about that? We might say, I'm not only putting him on the spot. I'm asking you guys in the chat as well. Anybody who wants to respond, but I mean, you're totally fine to respond and not respond when you want to, but it's very welcome. So diabetic ketoacidosis, right? So that's exactly right, Marcia. So you have bicarb is 17. That's low. So bicarb, it sounds like bicarb's trying to buffer the acidosis, and so what do you do in a metabolic acidosis first thing? Well, because we don't have electrolytes here, we're not going to do an anion gap. So the next step would be what? We would do Winner's formula. So hydrate is correct. You want to get fluids to this person for sure. That is a management answer that you'll see on step 2 a lot more than you'll see on step 1. So Carolina, you're absolutely right. But in terms of answer choices, I would say, and in terms of test taking for step 1, your next thought should be, I'm going to do Winner's formula. So does anybody know when? So we do Winner's formula when? When do we do Winner's formula? This is not for this question. This is just for like, I want you to get into the mindset where whenever you see a acid-base question, you think this might be a metabolic acidosis. I might have to do an anion gap, and I might have to do Winner's formula. And the reason I want you to do that is not because it's necessarily going to give you purchase on this question, but because as a test taker for step 1, you want to have certain associations that kick in every single time, and that's one of them. You want to notice that you're going to have an acidosis, that a diabetic ketoacidosis is part of that mud piles. So I'm going to write that into the comments, mud piles. Mud piles corresponds to non-anion gap metabolic acidosis causes. So we have M for methanol, U for urea, uric acid, D for diabetic ketoacidosis, which corresponds to this question, P for propylene glycol. All right, that's also ethylene glycol, which is coming up as E here. And then I is for iron. L is for, what is L in mud piles, you guys? Do you know? I'm trying to remember L in mud piles. E is ethylene glycol, and S is for salicylates. And lactic acidosis, I just remembered. So those are all your non-anion gap metabolic acidosis. So the question is, with this diabetic ketoacidosis, will you have an anion gap? What do you guys think? Just knowing as a category of metabolic acidosis, do you think that this is a non-anion gap or anion gap cause of metabolic acidosis? So ketones, exactly. So ketones. So how do you evaluate whether something will have an anion gap? What is the anion gap equation? You have your cations and your anions, right? So you have sodium and potassium, right? And then you have minus bicarb and this should be in parentheses, bicarb and chloride, right? So I'm putting these negative, I'm putting in the chat these negative and positive valences because they're important, because when we're talking about anion gap here, we're really talking about sodium. Some people leave potassium out because it's almost insignificant, completely insignificant. But exactly, anion gap over 12 would suggest that you have an anion gap metabolic acidosis, which you already know. You already know that this person has type 1 diabetes, probably has hyperosmolar, hyperglycemic state. This is a medical emergency, right? With a pH that's so low that you could give them dialysis, which is below 7.2, right? And so you take the anion gap would only be changed if you had a significant change in your bicarb or your sodium or your potassium or your chloride, right? So this is a situation where you have an increase in serum glucose for sure. After administering IV fluids and insulin, would you have an increase in serum glucose? So that's the question. So what do you guys think? What does insulin do? So I was teaching before, so I'm going to make a new template here. So I don't know if you guys have seen this diagram, but what happens when you have a lot of H+, which is to say you're very acidic in your serum? Okay, this is serum. What happens when you have a lot of H+ to your potassium in your cells? The answer is that the H+ effectively pushes the potassium out of your intracellular space into your serum. So you wind up being hyperkalemic, right? So if you got a bunch of insulin, yeah, it puts it into the cell. Exactly, Marcia. So what answer choice do we think about? Are we thinking for this question? What are we thinking for the answer choice here? I got to get at least one answer per question. Yeah, we're thinking 3. I just want to make sure you guys are paying attention. Exactly. I know Marcia is suggesting that it's 3. So when you take insulin, IV fluids and insulin, you're not even giving glucose with the insulin, which you would, or ordinarily you try to make sure that you give them some potassium before you hit them with insulin, which they should have done. They probably should have done. But so let's try that out. So we got that right here. So this is kind of like a basic physiology question concerning insulin and H+, from lactic acidosis, knowing what acidosis means in terms of H+, knowing that any acidosis will cause potassium to be extracellular. And then for step 2, you'd have to manage your insulin levels and your potassium. I'm not going to labor you guys with that. You probably have a lot of experience with that. Outside of the United States, you have a lot more clinical experience concerning management. So you're probably more prepared for step 2 than step 1. But as a step 1 question, we should limit our explanation to just understanding that intracellular potassium is going to increase when you take insulin. Another thing to keep in mind is that potassium, the net potassium in your body is actually decreased during a lactic acidosis because you're actually getting rid of it. But what's happening is your lack of insulin is causing the potassium to leave the cell. And then the H plus is causing the potassium to leave the cell. So it's kind of a double whammy. And then you take some insulin and it gets intracellular again. That's why you have to replete the potassium before you give them insulin, because when it goes intracellular, you can get to dangerous levels of hypokalemia when you give them insulin. It can be very dangerous to the patient. And they love to write questions about that. They love to write questions about potassium regulation in diabetic ketoacidosis. So can you guys still hear me, or we're still good? Let's move on to the next question here. So I'm just going to, does anybody want to field this question, read it out loud and give it a shot? This is another acid base. How do you guys feel about that? Do you want to try it? I know in the age of ChatGPT, it's not that fun to answer questions because everybody wonders, but I'll read it out for you. So a 73-year-old male is brought into the ED, emergency room, emergency department, unconscious with cold, clammy skin. His blood pressure is 65, palpable. There is no sign of blood loss. You recognize the patient is in an acute shock, and blood is drawn for investigation as resuscitation is initiated. So which of the following might you expect your laboratory investigation, might you expect in your laboratory investigation for this patient? So categorically, I like to just, obviously I like to call. So Fernando's saying 4 already, decreased hemoglobin. So maybe he's suspecting a certain type of shock, right? So what kind of shock is Fernando thinking that this might be if he's saying 4? What does that answer choice represent? So Marcia is saying 5, increased blood lactate. So what kind of answer choice is that? What kind of shock would that be? Really, all kinds of shock can cause blood lactate to go up, right?
What does blood pressure is over 65 means? I don't know the translation or the explanation.
Yeah. So that's a great question. So I think what they're trying to say is mean arterial pressure, what we call it MAP in America, because 65, it might refer to systolic blood pressure, which would be unbelievably low. Obviously, that's a really low. That's a situation where you're. I would say for yeah. So septics, people are saying septic shock. So I'm not sure what number this is. If they're talking about it being, it could be so many different things. It could be mean arterial pressure. So this is a poorly written question. So I would just for lack of a better explanation, I would call this just a person with hypotensive. Their blood pressure is just low. You could have a 65, diastolic, and you would still be within normal range. But a systolic blood pressure below 90 is really concerning. A 65 is at the point where you're cold and clammy, to say the least. But they even describe this person as acute shock. And they've initiated resuscitation. So if you've initiated resuscitation for shock, So I think what Fernando was getting at with 4 is hypovolemic shock, right? And Fabiano and Marcy are saying 5. What kind of shock are you saying that this might be? So septic shock, certainly you can have increased lactate as well, Larissa. Absolutely. So people are saying 4 and 5. So we got 5 the most. So why don't we septic maybe, yeah. So septic shock, if you had decreased hemoglobin, you could have septic shock because you have some kind of hemolytic bacteria that's causing your shock, but usually with decreased hemoglobin in the context of hypovolemia, in the context of hypotension, and with cold and clammy skin. Cold and clammy is a serious hint here because hypovolemic shock will definitely have cold and clammy skin, right? So we said 5 more than anything, so let's give it a shot here. All right. So were you guys thinking that this would be? So we talked about lactic acid as well. We talked about lactic acid being something that you see in lots of different types of shock. You're going to see lactic acid. When do you get lactic acid? You get lactic acid when you're not fermenting. When you're fermenting instead of doing the full cycle of. Have you guys covered biochemistry at all? It's glycolysis, right? And the Krebs cycle. So if you're not going on to the Krebs cycle and producing, lots of ATP, you're going to default to your anaerobic metabolism. You're going to start producing lactic acid as a result of that pathway. And so in shock, when you're not perfusing blood out to your end organs, you're going to have lactic acidosis. And so when they're talking about oxidative phosphorylation, inadequate cells impairs cells' ability to continue oxidative phosphorylation. They're talking about getting oxygen out to the mitochondria and allowing for the electron transport chain to produce ATP, right? And so it says shock has multiple etiologies. You can bet that somebody's going to have a blood lactate elevation during a period of shock. This is a generalized shock question. This is not about typifying the type of shock. And so your total hemoglobin might decrease during acute shock, but because they've already started resuscitation, you might not expect the hemoglobin to be dipping anymore. Yeah. And yeah, so they're making the distinction that if you lost whole blood, you're losing there's like in different types of shock, you're going to lose different components of the blood. So in anaphylactic shock, for example, you're opening your microvasculature from the histamine release, which is relaxing the smooth muscle, which is effacing the walls of the vasculature and allowing for small molecules like cytokines and immunoglobulins and albumin and things like that to leak out of your blood vessels. But the RBCs are not leaving, and the hemoglobin's not leaving the blood vessels. So you're not going to have decreased hemoglobin. You're not going to have haptoglobin go down and decrease. And so this is a generalized shock question. I'm not sure the educational value of this question is not as good as if we were doing UWorld, unfortunately. But I feel comfortable moving on if you do, because it is characteristic of all forms of shock that you're going to have a blood lactate level that is going to be elevated, in the context of a systolic blood pressure that's so low, which I assume that's what this is referring to. So it's unfortunate that we're using med bullets and we're not using UWorld. If I get enough people who are voting to, if we get some small groups together and people want to study using UWorld and Ambos, I don't like having large groups with Ambos or UWorld because it winds up being making me susceptible to copyright infringement and things like that. So this is going to be a good question, I think. So these are some nice images to be using for. So does anybody want to? Yeah. So these are short questions. So you guys can just call out the answer in the chat and let me know if you're thinking about anything in particular as you read this. But a pathologist is reviewing a number of unlabeled liver biopsy slides, which need to be assigned to the correct patient. Which of the following slides best corresponds to a patient who has a history of type 2 diabetes, obesity, and hyperlipidemia, but no history of alcohol intake or liver pathology? So this is going to have to do with, so Carolina's giving us an answer already. So figure A. So what do you see in figure A? What do you see a lot of in figure A? Lipids, exactly. Is this Carolina I'm talking to?
Yes.
Exactly. So what do you notice about these spots that
Vacuolization.
It's what?
Of the cells. Vacuolization of the cells.
Exactly. In a vacuole, just when you talk about vacuolization, you're talking about like kind of a space where there's no staining. And when there's no staining, it's because the
Yes.
fat is lipophilic. It's like the stain is not lipophilic, so it can't stain the fat, and so it stains everything else. Exactly, Carolina. So that's great thought process. We didn't even have to look that closely at these other slides because we're able to. We didn't have to look more closely at this slide because we can see the fat is definitely there. So what about the fat suggests that the answer would be A? Sometimes people who are who have type 2 diabetes, who have obesity, who have hyperlipidemia, they have a lot of risk factors for a certain diagnosis, which is kind of a diagnosis of exclusion. But it's if they're not an alcoholic, then you might think that they might have a fatty liver. That's a hint. So non-alcoholic fatty liver disease. And so
Steatosis.
exactly, steatosis. Exactly. So this almost looks like a glomeruli. I'm wondering what this. Okay, no. Okay, so we can hear their description, but you're exact. This is non-alcohol. So I got it wrong with you. So let's see what this. So this fifth one actually has a lot of fat. So let's look at this together. So diabetes, obesity, hyperlipidemia are risk factors for non-alcoholic steatosis. So this is NASH as opposed to non-alcoholic fatty liver disease. So this is non-alcoholic steatohepatitis. These terms aren't exactly interchangeable, but they are used in very much the same context here. So you would expect a lot of fat in a steatohepatitis, right? So the question is, what is this versus what is this? And so let's read the wrong answer choices and see. What is wrong with this one? We didn't look very closely at these images. This is acute hepatic necrosis seen in acetaminophen toxicity. So acetaminophen is a horrific way to commit suicide if you're not serious about dying very quickly. It is a very deadly drug. Toxicity with acetaminophen can result in hepatorenal syndrome and require that you get a transplant for your liver or your kidneys. So it's very, very, very dangerous way to try to kill yourself. Acute hepatic necrosis apparently looks more globular, larger fat molecules here. I would need to brush up on exactly the histology of necrotic hepatitis. So I field these questions randomly because I want to demonstrate that, because I know there's a lot of people who teach step one who don't field random questions, and I'm not that kind of tutor. I do questions all day, every day when I'm tutoring, and so you guys know that I'm not reading from a script and preparing 5 minutes before you do to pretend to know all the answers. So drug microvesicular fatty changes. Yeah. So they call them microvesicular. And you're right to call them, vacuolization, because they do look like vacuoles. But that is it's good to do what Marcia is doing, which is characterizing the histology in a written format and understanding the exact wording that the test will use to describe the histology. So I love Pathoma. I love Boards and Beyond, obviously, but I think Pathoma is really good for exactly describing the words that you might see on your exam on test day, especially for pathology. I know it's an old school resource, but we used to call it UFAP, which is UWorld First Aid, and Pathoma, and people would only use that, and all of a sudden their scores were rising and meteorically. And obviously Pathoma is also on King Deck, but macrovesicular metabolic, yeah. So that's you really want to get used to the terminology, because you guys are well educated. You guys, I know the doctors here are fabulous. They're very good. The problem is the test is full of all of these specific testisms that are made specifically for the step 2 and the step 1. Especially will have these terms that are American specific descriptions of histology, which makes histology even harder for you guys. And so it's really good to do what Marcia is doing, describing these, the histology, and Carolina were doing, describing these pathologies in exactly the terminology that you're reading about in your resources for the exam. So So the correct answer choice was NASH. Why was NASH the correct answer? Alcoholic steatohepatitis in illustration A, so that's not the correct answer. Illustration E was correct and filled with fat droplets, but you have to make sure that you see the architecture of the hepatocytes themselves and that the fat droplets are within the hepatocytes, as opposed to these large distributions of fat. And you can see that there's necrosis here. What do I mean by that? It's really clear because you have what do you have? You have a loss of the nucleus. So you have anucleated cells here. That's a sign of necrosis. So and you can see there's a lot of also collagen, and these fat globules are not inside of hepatocytes. These fat globules are larger than hepatocytes, and so in this necrosis, you're going to have a distribution of fat that is much larger. They could not be characterized as droplets, and they could not be characterized as intrahepatocytic. You know, these are fat globules as opposed to droplets. So people are joining a lot. I think we're dropping them accidentally from the connection. So thank you for tuning in again. So let's move on to the next one. And I'm going to send you guys a code to go through these questions on your own, and they're free to access. So you can read these explanations, take notes on them, add them to your Anki if you like. So look at this rash. I mean, we're already starting to get ideas as to what the answer might be. You guys might have some ideas already. But a 3-year-old female presents the emergency department with colicky, abdominal pain, polyarthralgias, which is just pain in multiple joints, and palpable rash, shown in Figure A. Your concern for the complication of her disease may include. All right, so what are you guys thinking?
Oh, well.
Yeah, 2. Okay. So what about 2? Yeah, so glomerulonephritis. So what kind of glomerulonephritis are we thinking has especially on the buttocks, on the posterior leg, will have, you know, palpable purpura, so to speak? Because this is a palpable rash. Does this look like purpura to you?
Yes.
Yes. Yeah. So you guys are thinking along exactly the same pathway I am. Meanwhile, MedBullets likes to get very persnickety and create these unbelievably misleading formats. So we'll see how it looks. But let's talk about these answer choices, okay, for a little bit. So rheumatic fever, what kind of rash would you see there?
Mm.
Do you guys remember the, you guys have, there's Janeway lesions, and you guys have Koplik spots, and you guys have lots of different kind of rash-associated infections, right? Respiratory infections. So when they talk about deafness, do you guys know what they're referring to?
Cytomegalovirus.
Cytomegalovirus can. So will you have sensory neural hearing loss? Yes, you can. Yeah. But that would usually be congenital. I think it's usually congenital cytomegalovirus that causes the sensory neural deafness, because this is a 3-year-old. So it's a little bit older. So I would be more prone to think that cytomegalovirus in a immunoincompetent, non-congenital form of CMV, I would expect more to present usually with retinitis. Usually you have CMV conjunctivitis. Sorry, I said retinitis, where you have a reddening of the sclera. So this is Hinoch-Schönlein, they're thinking. Yes, yeah, vasculitis A. So CMV is probably, it might be what they're getting at. Just to try to sway you, but I think the age would be. So you're right to characterize that answer choice. Rheumatic fever, the rash. So you can have Osler nodes, Janeway lesions, aortic regurgitation. You could see aortic regurgitation in rheumatic heart disease. It's usually the mitral valve, right? It's usually mitral stenosis early on. It would be mitral regurg, and then it becomes mitral stenosis, right? And then septic shock, I'm not sure what they're getting at. It could be petechiae from, like Shigella infection. or EHEC, which is the hemorrhagic E. coli, right? So let's go for E because everybody's saying E, right? Erythema infecciosa. Yeah, that's a good one. That's a good differential. I think these are these are palpable, and usually that's a little bit younger. So let's see here. Yeah, IgA C3. So 3 to 11 years old. Let's see what the incorrect answer choices are. I'm very curious to the congenital. So this is rubella. So you get the blueberry muffin rash is very classic. I don't know if you guys use Sketchy Micro, which I think is lovely. I think Sketchy Micro saved me. I think it saves a lot of American students use Sketchy. I've heard you guys talking about it in the comments. So you guys, if you're not aware of it, it's a really nice resource even while you're in med school to use. So I think they're talking about erysipelas and impetigo, cellulitis from group A. This is GAS is group A streptococcus. They are talking about rheumatic heart disease for aortic regurg. And meningococcemia, you will get petechiae. So if you had a disseminated intravascular gonococcal infection, then you could have septic shock, certainly. But usually that would be in an adolescent. Palpable purpura, it's it's unusual to describe a meningococcemia with purpura. And often they will get actually meningitis. And so you'll have fever and a headache, and you'll have, signs of meningitis, which will photophobia, and you'll have when you move your neck, you'll have a Brzezinski sign, they call it, where you actually raise your feet to allow room for your meninges your inflamed meninges to move. So this is congenital rubella. I think it's a good thought to think about CMV though. But congenital rubella, again, you'd notice this at almost at birth. You'd have some characteristics of congenital rubella. So this is a 3-year-old. And this is classic, you guys, like to recognize that when you have a rash in this specific distribution on the buttocks and the posterior legs, and it's palpable, it's very likely to be Henoch-Schönlein purpura, which is an IgA nephropathy. They're more and more, they're going to call it, things like leukocytoclastic angiitis associated with IgA and C3 deposition. They're going to start using those kind of terminologies, unfortunately. It's also very good to talk about which vasculitides are small vessel and which vasculitides are medium vessel, like Kawasaki, and then which vasculitides are large vessel, like giant cell arteritis. And microscopic polyangiitis is very, very highly tested as well, most common. Yeah. So, they used to call polyangiitis with, So there's eosinophilic polyangiitis and granulomatosis. And then there's polyangiitis and granulomatosis, which is Wegener syndrome. So those are small vessels, right? Yeah, so palpable purpura, there's a few things that can cause it, but this is classic in a 3-year-old especially. They usually be younger than 11. Usually these questions like to go after, toddlers, which is usually under 4 years old. That was great. You guys are, some of you are a little further along in your studies as well. I can tell because you're picking up on some, like, the step one classic, really quickly seeing that picture and moving to the correct answer. So I'm encouraged by that a lot. So a 19-year-old man is seen by his primary care physician. The patient has a history of excessive daytime sleepiness going back several years. He has begun experiencing episodes in which his knees become weak and he drops to the floor when he laughs. Interesting. So he has a history of marijuana use. Family history is notable for hypertension and cardiac disease. So his primary care physician refers him for a sleep study, which confirms your suspected diagnosis, which with following is the best first-line pharmacological treatment. So it's not even asking for diagnosis, but I'll ask you guys, what do you guys think this guy has? I'll give you a hint. I know you guys are going to start pouring in the answer. But what do you guys think?
Sleep apnea, maybe?
So sleep apnea is a good. So you're right in that sleep apnea could cause someone to have an abnormal sleep study, and that is how sleep apnea would be diagnosed is obstructive sleep apnea. Now, if you experience episodes where your knees become weak and drop to the floor, this is the reason why I can't say sleep apnea right away. So sleep apnea, usually they'll mention obesity as a risk factor, diabetes, and usually they'll mention intense snoring, waking up feeling more tired than they would ordinarily be. This is excessive daytime sleepiness, which can happen in sleep apnea. So it's a really good differential. It actually is a really good answer, sleep apnea. The problem is, especially with hypertension and cardiac disease, right, in the family. So some people are saying narcolepsy. Vasovagal is a great answer. And I thought about vasovagal as soon as they started talking about episodes in which the knees become weak and drop to the floor, right? When laughing. Why do you get does anybody know? Yeah, so why do you get a vasovagal? You get a vasovagal because you have an obscenely high parasympathetic response to something. And it usually has a prodrome of, a little bit of diaphoresis where you're sweating and, quick breathing. And it can happen when you see a mouse, and you have an emotional response to something like intense exercise or, sometimes people get it when they eat a hot pepper, but it's kind of like an emotional passing out because of an emotional trigger. And I'm not seeing that emotional trigger here or the prodrome. And the excessive daytime sleepiness is very suspicious. The fact that they refer him to a sleep study and it confirms the diagnosis rules out vasovagal, right? Because it has to be sleep related. So what is this passing out thing before we get to the diagnosis, which you guys are right, that it is narcolepsy? And Marcia's even giving us the drug of choice here, and I'm going to talk about that. So if he drops to the floor, it's cataplexy. Cataplexy is just like a vasovagal, except that you have an emotional, trigger or something triggers you to pass out. Another characteristic of this diagnosis is hypnagogic and hypnopompic episodes. Hypnopompic is when you're waking up from sleep. I think of Pompeii, the volcano, when it's erupting, and that helps me remember that they're waking up. I don't know why, but you have kind of like a dreamlike state where you're not able to move your body, but you are dreaming and kind of seeing images that you remember upon waking, and you feel kind of locked in your body as you're watching these hallucinations. And then hypnagogic is when you're going to sleep, I believe. Yeah, they're like hallucinations. It feels like a dream upon waking, but you're not able to move. Yeah. And so modafinil. Why do you take modafinil when you're narcoleptic? What does it help you do? Does it help you sleep at night? No, right? It's an amphetamine. It's an amphetamine. It's really good to pay attention to the fact that this is not only an amphetamine, but it's also one of the cytochrome P450 inducers. So it induces your P450. So if I was taking an OCP, right, and I had high risk for endometrial cancer, I could take modafinil and it could cause me to decrease the amount of OCP that I have in my bloodstream and wind up giving me susceptibility to getting pregnant even though I'm taking an OCP, right? And so, or if I was taking warfarin for atrial fibrillation to prevent clots and prevent strokes, I could take modafinil and it would decrease my warfarin. My INR would go down again where I don't want it, and I could start throwing clots to my brain, right? INR going down is bad when you have atrial fibrillation. That's why you're taking warfarin to begin with, right? Your INR talks about how clottable your blood is. So modafinil is a drug that keeps you awake during the day. You take it in the morning, and it keeps you awake all day. But you have to worry about that cytochrome P450 inducing, because it will decrease the amount of those substrates. Those four substrates that they like to harp on are anticonvulsants. They like to talk about OCPs. Does anybody know some of the other ones? These are the substrates of the cytochrome P450 inducers and inhibitors. So warfarin, OCPs, anticonvulsants. Anybody know the last one? It's in first aid. Somebody give it to me. This is a good question. This is one to look up for sure. I'll leave that for the comments, but you're absolutely right, Marcia. So this is a really good question to talk about many different topics, because cataplexy is something not to miss. When they mention something like that, you should think about vasovagal, absolutely. And then you should rule it out when they talk about sleep studies, diagnosis with that. That's when you start thinking, maybe not. Laughter, anger, surprise. It's just like you could laugh yourself into a vasovagal, absolutely. And these questions will will poke at that for sure. Wide spectrum, ranging from sudden loss of jaw muscle tone. So you could just have a description where your jaw is dropping, as opposed to, that's really interesting. I've not seen a question on that, but it's fair game. So another thing to understand is that these other drugs are just not related to either vasovagal or anything other than anything related to narcolepsy. So these are not drugs that you would take for sudden loss of consciousness or other causes of fall, really. Zolpidem is a drug that is a it's a non-benzodiazepine drug that you would use to try to fall asleep. Methylphenidate you use for kids, as it's a somewhat addictive drug that people use for ADHD in children. Lisdexamfetamine is something that people use for binge eating disorder. It prevents your appetite from getting outrageous. It can also be used as an amphetamine and other off-label for ADHD and things like that. Dextroamphetamine is classic first line for ADHD in adults. And there's kind of an epidemic going on of over prescription of dextroamphetamine as a study drug, and as well as a amphetamine for people with. I think they're diagnosing a lot of ADHD these days. I'll just put it that way. But this is cataplexy. This is classic here. So we started at 2. I'm going to go till 4, you guys. I don't know how that sounds. If you guys feel like sticking around, we got 11 people here. Give me a thumbs up if you're going to stick around until 4. We can call it a little bit earlier than that, and I'll send you guys the code. You've been awesome so far. So let me know if you're getting tired, but I'm going to keep going. The 23-year-old woman presents the emergency department with acute onset shortness of breath, wheezing, and chest tightness. This is her 4th visit for these symptoms in the last 5 years. She tells you she recently ran out of her normal controller medication. Concerned for asthma exacerbation, you begin therapy with a short-acting beta-2 agonist. What is the expected cellular response to your therapy? You guys still with me on this? So this is classic step 1. You'll never see this on step 2, ever. But this is your GS, GQ, GI, knowing the associated effects of a short-acting beta 2.
Use the first option.
Okay, so you think 1 here. All right. Okay, so I'm seeing these answers. So Leslie's saying 1 too. Hey Leslie, I didn't see you there. Cyclic AMP. All right. So yeah, so beta 2. So there's a page, all right, on first aid that you should go to, and you should memorize it. And I love that people are answering this question with confidence, because it is so high yield, and they have an absolutely fabulous mnemonic in first aid for this. I won't say it here, okay, but you can look it up on ChatGPT. They'll identify what I'm talking about for first aid. But you should go to your first aid book. You should always look up things you don't know, because the act of looking things up is in and of itself instructive for the exam. It's good to map it out and have a scaffold through which to hang all of your knowledge. And that first aid book works that way. That's how it works. You want to read every single chapter of first aid, and you want to read it slowly, but understand, look at the categories. Look at the categories of knowledge. Look at the where you're going to find the information. Then go through your Q bank, get things wrong, get all of them wrong if you have to. Read about each question that you get wrong in your first aid book, and it'll help you kind of navigate these questions. But this mnemonic is absolutely key. There's no reason to use any other method to understand these GS, GQ, GI associations with beta 2, beta 1, alpha 2, beta 3 even in your general urinary tract. Alpha 2s in your central nervous system. Understanding where these things act on what types of muscle, what types of receptors, in what parts of the body, and then understanding which of these GS, GQ, and GI. That's probably one of the most high yield things you can do, and a lot of students don't do it. And so it leaves them susceptible to every question that incorporates this knowledge, which they write a ton of questions and then they add this as the last little polishing detail. Is it a GS, a GQ, or a GI? So this is a classic, like, I studied in a country that doesn't care about, because you could make a very strong case for not needing to know this, right? These are the G-coupled protein receptors. GQ, GS, GI. Understanding these pathways is not necessarily what every doctor does in every country, and I think that's with good reason. But for the USMLE step 1 exam, you need it. It's so high yield. So I love that somebody said that. I don't know who said it. You're welcome to yell it out. You got it right. Thank you for saying that. So you really do want to look at that pathway, and the main things to remember are which receptors activate the GS, GQ, or GI, but also knowing that adenylate cyclase has to do with GS and GI, whether you're activating or deactivating it. Adenylate cyclase. And so if you have more cyclic AMP, it's because you have more adenylate cyclase activity. It's converting to cyclic AMP. It's increasing cyclic AMP, which usually, whether it will actually cause a muscle to relax or to constrict will be determined by what type of cell you're in. It actually won't be down to what receptor you're using. It'll be down to what type of cell you're in, because different receptors actually cause different effects on smooth muscle in different areas of the body. So somebody is already saying 5. I think because they said cyclic AMP already, they're talking about this question already. So we're on 8 of 40, and I think Marcia's saying it's 5. Correct me if I'm wrong, Marcia, here. But a 58-year-old lifeguard developed squamous cell carcinoma on the skin on the forehead. So this is a sun-exposed area. Which of the following is most likely preceded the development of this carcinoma? So I'm not even going to spend that much time on this one. You're right, Marcia, absolutely. Oh my God. Okay, so dry scaly hyperkeratotic papule, they're talking about actinic keratosis. So this is a precancerous, so they said preceded development of the carcinoma. They're talking about hyperkeratosis, actinic keratosis. So obviously UVC, it's actually UVA and UVB that are very prone to producing skin cancer. UVC is not so much. They were using UVC actually as an anti-COVID. Like they would, I guess, destabilize or denature the protein in the air. There was an attempt to use UVC. It's not very common in the air in normal daylight, or you would never get COVID when you left your house. And this whole hypothesis of UVC being a cure would be more harebrained than potentially it was at the time. But dry scaly hyperkeratotic papule, they're talking about actinic keratosis, which is a precancerous. I hate that they mention dry scaly hyperkeratotic. Hyperkeratotic, absolutely. Dry scaly, absolutely. But the white splotches on actinic keratosis are particularly noticeable. And when they don't mention it, it always bothers me, because I lived in Australia for a while, and people would get actinic keratosis all the time. They get squamous cell, and I would do excisions all the time of squamous and basal cell carcinoma, and it is white. There, I mean, not always, but there's white splotches, little white dots will definitely clue you in that this person in a sun-exposed area like the forearms and the forehead and the ears and the sides of the face, usually the upper part of the face. They talk about whether squamous cell is more likely on the upper lip and the lower lip on step 1 a lot. Basal cell is more likely on the lower lip. Squamous cell is more likely on the upper lip. That's because of the sun. So, Marcia, I think your answer was perfectly valid, except it would be UVB and UVA. Because you're thinking about the sun, and that's what you should be thinking about with squamous cell carcinoma if you're not thinking about smoking cigarettes, right? which would be a central lobular cancer. Not at all, Marcia. Thank you for participating. And honestly, it's a good answer. It's because you're talking about the scruple between UVB, UVA, and UVC. It's not a very commonly tested thing. UVB, absolutely, UVB, and squamous cell carcinoma of the skin is highly associated with smoking. So not just central lobular small cell and squamous cell carcinoma with cavitary lesions or a paraneoplasm, like SI-ADH, but this is a skin cancer. You can get squamous cell skin cancer from smoking very easily, and they like to talk about 5-fluorouracil being a drug that they use to help you with squamous cell carcinoma of the skin. In step 1 and step 2, they talk about this. So this is a penis here. I'm not sure what we're supposed to be. So there's a little, you can see under the glans penis, there's a little divot there. I think that might be what they're referring to. So there's a defect in an adult. Newborn male have urethral opening on the ventral side of the penis. So that's exactly what they're pointing to. So what would we call this? Yeah, so Leslie says 3. Romulo's saying 2.
Hypospadias.
Exactly. Hypospadia, exactly. So incomplete fusion of the labiosacral swelling. So the labia on a female corresponds to what on a male? Do you guys know?
Scrotum.
Exactly, the scrotum. So if you had an incomplete fusion of the labiosacral swelling, you might have a defect in your scrotum, and you might actually have, a serious problem. It's a very unlikely scenario where you have a labiosacral defect that is going to cause the testicle to fall out. It would be a very life-threatening moment. Infection risk would be enormous, but yeah. So we're talking about the urethral folds and incomplete fusion of the urethral folds. So urethral folds is going to correspond to hypospadia. Dysgenesis of the genital tubercle. I think we're talking about dissension of the governaculum and dissension of the testes. So people are saying 2. So let's go for 2 because we got 2 is the most common. Yeah, let's try it. All right. So it is hypospadia. That I think that picture is definitely a hint here. So male and female genitals arise from precursor embryonic structures. So I would just again, refer you to first aid and looking at those diagrams where they colorize the female and male genitalia and what the embryonic precursors are to the adult tissues. Because you can really get a sense of how the clitoris is the female equivalent of the phallus, but the labia on the female is actually similar in developmental precursor to the scrotum. And so you can look at that. And you can also, really a clutch diagram on first aid is the description of Sertoli cells, Leydig cells, the hormonal disruptive disorders, what happens to the development of the Müllerian tubes, the upper vagina, the lower vagina, the external genitalia as a result of hormones. And they do a really good job visually demonstrating why certain organs will develop in what way. Now, this is not a hormone problem necessarily. This could be just an anomaly, defect during embryonal growth. And their failure to fuse can happen kind of as a defect during birth. Malnutrition can be a risk factor. Certain drugs that the mom might take can be risk factors, but it's usually not hormonally mediated. A thymic sample from a fetus is examined. One cell type found was double positive for CD4 and CD8, both. What is the identity of these double positive cells? So what? Yeah, so Marcia, exactly. Marcia. So 3, immature T cells of the thymic cortex. So why are you saying that? That's a great answer, Romulo.
Because both CD4 and CD8 are T cells.
Yeah, and what does that say to you?
It's more immature.
Yeah. So what didn't it go through?
Differentiation.
Exactly. So I would say it a little differently. I know that you're saying it because you know the right thing. I'm putting you on the spot because you gave a great answer and you're absolutely right. But there's positive selection and negative selection in the spleen, right? So positive selection is like, do you have the ability to bind the way that you should as a CD4 or CD8 T cell? And the spleen will test you on the red pulp and the white pulp. It will test you on whether you're binding sufficiently such that it won't kill you, because the spleen is all about killing cells that are not worthy, right? It gets rid of our red blood cells that are nucleated. It gets rid of our helmet cells. It gets rid of our the cells that have Heinz bodies. It's the destroyer of defective cells. So it's doing positive and negative selection. Positive selection when the cells that are supposed to be able to bind are able to bind, then they move on to negative selection, and the cells that are unable to bind, they get scheduled for cell death, right? So they get apoptosis. They get signaled for apoptosis. Whereas in the negative selection, if they bind too tightly, they can be scheduled for cell death as well. So these cells have not gone through positive or negative selection yet, and so they're immature. Yeah, they're going to lose their CD8 and their CD4 capability, their biomarkers here. So when you do a cytology, this is the result of cytology would tell you whether you had CD4 or CD8. And it looks like kind of a chart where they have, CD4 labeled, and it'll have a bunch of dots there. Cytology will show a bunch of dots on the CD4 and then a bunch of dots on the CD8. And then some of the dots will be in a CD4 CD8 positive. And so this is just getting you ready to understand what double positive means. When we think about CD4, what kind of cells are those usually? That's the cell count that we're thinking about for HIV, right? We're thinking about for AIDS defining illnesses. So that's T helper cells. Whereas CD8, those are going to be cytotoxic T cells. So if you're both, Romulo is exactly right. You're probably an immature T cell. But are you in the thymic cortex or in the medulla?
I have no idea.
Okay. So I'll be honest with you. I'm having trouble remembering which it is too. So which do you want to go with? Do you want to go with 3 or 4?
3.
All right, let's go with 3. Okay, so it is the cortex where they do immature T cells begin in the double negative, follow T cell receptor rearrangements. So they're talking about positive selection, is exactly what we just talked about. Negative selection is accomplished in the thymic medulla. So negative selection is the process that happens afterwards, right? And this is responsible for apoptosis of self-reactive T cells. These are T cells that bind and bind too tightly, right? So that happens in the medulla. In the cortex, you have positive selection. And that's what they're trying to get at. So I actually like this question. I think this question is actually pretty decent. And we did really well. I think that was a good answer. Let's keep going. So a 65-year-old woman comes to clinic complaining of pain with chewing solid foods. What do we call pain with chewing solid foods? Because this is a word that's going to come up a lot, and it's so diagnostic. I guess it's really not chewing foods that I'm talking about. I'm more talking about swallowing being painful. What would we call painful swallowing?
Dysphagia.
Exactly, dysphagia. Yeah, that's the word that I want to talk about, because esophageal problems, usually we talk about dysphagia, and it's a huge distinction on step 2. I just want to get you guys primed to think about it. So although they're talking about chewing solid foods, so let's be specific. This is chewing. But you're absolutely right. That's dysphagia. So she reports that she has been feeling unwell lately, with pains in her shoulders and hips, and she has lost 5 pounds in the last few months. Her vital signs are, so she has a fever here. Respiratory rate is 18, heart rate is 95, blood pressure 120/65, kind of a low diastolic. When you ask her to stand on her chair to get on the exam table, she moves stiffly, but displays preserved proximal muscle strength. So preserved meaning good, right? So yeah, so crest, yeah. That's a nice thought. So what do you mean by crest? Yeah, so what is crest referring to? Romulo's saying 5 as well, thick and tight skin on the fingers. So we have 2 crest people, I think. I'm putting words in your mouth, but you're saying crest and 5 together. What is crest? What's the diagnosis for crest?
Scleroderma,
Yeah,
esophageal dysmotility, and
that's this exactly. That's the systemic scleroderma. Because there's scleroderma that's non-systemic and there's scleroderma that's systemic, right? Now, when I heard chewing solid foods and dysphagia, and I knew that I was on med bullets and we were talking about step 1, these extraneous diagnoses, sometimes they come out really quickly in your mind and you start thinking about certain diagnoses because dysphagia is one of the characteristics of scleroderma, right? Pain in shoulders and hips is suggestive. Lost 5 pounds. So so what I like to do as a test taking is if you start to lean towards an answer too quickly, I try to rule it out, but I also try to rule other answer choices in. So let's talk about what are the diagnoses that they're talking about for each of these characteristics. So easily sunburned on the face and hands. What would that be? That'd be like xeroderma pigmentosa. Have you guys heard of that? That's when you're really easily burnt. You have skin rashes that are really, really characteristic. They're very color. You know, once you see pigmentosa, your retinitis pigmentosa, but xeroderma pigmentosa is very striking, and that's a chromosomal. That's not a chromosomal, but a genetic abnormality of I think double-stranded breaks. If I'm not wrong, somebody correct me on that. If I think it's double-stranded breaks. Violaceous rash across the. It's a correction of DNA that you have inadequacy of. Violaceous rash across the eyelids. What are we talking about there? You guys know? Should we just look at the answer choice and? All right, we said 5 very confidently, but it was actually blindness. So why was it blindness, you guys? What are we thinking about for blindness? This is only 25% of people got this right. So something
doesn't
that
make
gives.
much sense for me.
Yeah, this is a hard one. I think this is. I think this is an extremely difficult question. But temporal arteritis. So, what do you get with it? Just before we look at the answer choice and why it's temporal arteritis, what do you get with giant cell arteritis? Headache, absolutely. Is it unilateral or bilateral usually at first? Terrible headache, yeah. Unilateral. It's usually like it's the temporal artery, right? So it's the temporal area. And what do you do? This is one of the only this is the most clinical thing that you do on step 1. That, of course, you do it on step 2, but step 1 actually has a clinical thing that they want you to know about temporal arteritis. What do you do with temporal arteritis? When you see a patient that you think might have temporal arteritis, what do you do about it?
Ophthalmoscopy, like see the.
You could look at their eye. You could look at their eye to get it because you have plenty of time, but you don't want to do something else. If you look at their eye, you're still in the stage of like maybe this is giant cell arteritis, and that's the right thing to do is do a physical exam, a thorough physical exam. So absolutely. But what I would also do, yeah. So Sergio, okay, so you fell into my trap, Sergio. I'm sorry, But but you're thinking exactly right in terms of what would we do if we knew that that we had to diagnose temporal arteritis. We might do a biopsy. The reason we don't do a biopsy right away is this answer choice. So this is a very type step one, exactly, corticosteroid. So you want to give prednisone, and you want to give prednisone what is called empirically. What do I mean by empiric prednisone? I mean that I'm giving prednisone to diagnose and treat the temporal arteritis before it causes blindness. So I'm worried that this person's going to go blind. So I might look at their eye, but I'm not going to do the biopsy because the biopsy would take too long to come back and give me an answer. So what you'd see on biopsy is you'd see granulomatous tissue, you'd see the histological signs of temporal arteritis, which is a large vasculitis. So we talked about Kawasaki being medium size, temporal arteritis being a large vessel vasculitis. And we talked about polyangiitis with granulomatosis being a small vessel, as well as Henoch-Schondlin, which we saw earlier, right? These are all vasculitides. But with temporal arteritis, you want to do the biopsy after you treat the disease. That's why it's empiric prednisone. So you're going to give a high dose prednisone. And why do you give prednisone? Why does glucocorticoid work to decrease a vasculitis? It's because there's something called annexin, which is in the pathway of inflammation, that it will decrease. It'll decrease your annexin. And your annexin will, as a result of decreasing your annexin, you'll decrease immune response. You'll decrease the inflammation that you're seeing. Inflammation technically being the release of fluid from your microvasculature, right? And without that inflammation, you won't get the inflammatory cells. Without those inflammatory cells, you won't get cell death and necrosis from these cells taking care of, basically whenever you have overinflammation, chronic inflammation, you get cell death and tissue damage because the white blood cells are looking for something to kill. And they know from the constant inflammation that there's something your body's signaling to kill. And so eventually it starts throwing grenades in the form of major basic protein. Do you know what cells produce major basic protein? And somebody tell me in the comments, but it starts causing damage to the tissue. And that's what you're trying to avoid, which would produce blindness in this patient. And so you want to give, so I'm just going to show the answer choice here because it's such a clinical thing. This is such a and the point is that they're getting joint pain from the polymyalgia rheumatica, which is in they're saying 50% of patients with so not every patient that you see, this is super important, not every patient that you see with giant cell arteritis is going to present with arthritis at all. 50% of them never get polymyalgia rheumatica. It's just an association. But it's a pretty high percentage, right? And if you get temporal arteritis, you run the risk of getting blindness. It's an autoimmune disorder, so you're using glucocorticoids to decrease your immune response and try to spare the eye. So then you get the biopsy. And so they actually have to put you under and take a surgical biopsy of your temporal artery. So that was a really good one because that's one where if you're thinking really clearly, you can still get it wrong because it's one of the only really very clinical management things that they want you to know on step one. So once you see it, you'll never get it wrong again. A 61-year-old male is given acetazolamide to treat open-angle glaucoma. Upon diuresis, his urine is found to be highly alkaline. Which of the following accounts for alkaline nature of the patient's urine? So what does acetazolamide do in the kidney? Because this person's using it for glaucoma, right? But what part of the kidney does acetazolamide act upon? Do you guys know? Urine alkaline. Yeah. So it will make your urine alkaline. But what part of your kidney? So I'll tell you in the eye what it does. Acetazolamide is carbonic anhydrase. So you're saying anhydrase. So this is specifically carbonic anhydrase 1. Because there's actually more than one carbonic anhydrase exists in your body. And so these acetazolamide that you're giving for open angle glaucoma is intended to decrease your choroid plexus production of vitreous humor. And that's going to alleviate the symptoms of acute angle glaucoma, open angle glaucoma, wherein you have an overproduction of intraocular pressures accumulating as a result of inadequate drainage of fluid from your eye through the canal of Schlemm. Okay, and so acetazolamide is in your is going to block an enzyme called carbonic anhydrase, which is in your pigmented epithelium of your eye, in the anterior chamber behind the iris, and in the matrices, and it will treat open angle glaucoma. The problem is, or not so much a problem as it is, it's additionally used in if you have acidemia, right? Because you're going to block carbonic anhydrase in your proximal convoluted tubule is the answer. So it's the proximal, it's the PCT, proximal convoluted tubule, right? Oh shit, I gave the answer away. So what's the answer, you guys? Well, what do you guys think the answer is? Maybe I'm wrong, because I was wrong before. I got one of the questions wrong. 4. Okay, we're thinking 4. All right. You guys have too much faith in me. We'll see if it works. Okay. Yeah. So you guys probably knew the answer anyway. I'm just saying that you. Yeah. So you guys are absolutely right. Marcia and Leslie got it right here. So this is bicarb. So when you reabsorb something, is it going into your body or out of your body? I know this sounds really obvious, but I'm making a point about studying renal overall, because it's a problem I see in students all the time. Reabsorption means it's going back into your serum. Secretion, does that mean that it's leaving your body or entering your body? It's leaving, right? So these are terms that reabsorption and resorption are different. When you resorb something or absorb something or reabsorb something, those are all different things. And I urge you to go and look up the differences in terms of renal physiology, because secretion, I'm going to write them out into the text. Secretion, reabsorption, absorption, and resorption. These are persnickety details that matter a lot on step 1, and you want to have them cold. You're going to read them 1,000 times. You might as well understand them every time. So what happens is when you produce H plus and it's sent out into the proximal convoluted tubule, because of the Henderson-Hasselbalch equation, which you guys might remember, it has to do with CO3 in chemistry and H2O and regulating H plus molecules. And there's this equation where you use Le Chatelier's principle to decide whether H plus is going to go up or down, on the basis of what's happening to your bicarb and your H2O and your hydronium ions. So it's a very chemical thing that happens. But when you release your H plus into the lumen, which is to say you secrete it, right, out of your body, in the lumen is outside of your body, you're going to urinate it. It's going away. Then carbonic anhydrase will actually cause you to release chemical. I think it might be. I can't remember exactly. It's CO. Yeah, it binds to the H plus molecule and becomes bicarb. And as a result of becoming bicarb in the lumen, you wind up urinating bicarb. And when you urinate bicarb, you have alkaline urine, as Marcia said. And so this can affect drug delivery, you guys, and it can affect whether drugs will work in your body. It affects your pH of your serum as well. So it's not it's not that it's an unsafe drug, it's just that it has serious effects that you need to pay attention to in terms of drug and drug interaction and urine pH, because you can make yourself susceptible to urinary tract infections. And when you're doing a acid-base question, acetazolamide is classic right? Because you're getting rid of biparb. Okay. If you guys have any questions, definitely pipe up and we'll talk about it. I know these acid-base ones are like very high yield. And people get confused by them quite a bit. I do too. I still do acid-base and get my signs flipped. So what are we seeing here on their fingers? What do you guys see in this person's fingers here?
Edema.
Edema, yeah, it almost looks like dactylitis. Do you know what I mean by dactylitis?
Not really.
It's exactly what you're saying. It's like, sausage fingers, big joint fingers, right? These are not Heberden nodes necessarily. Heberden nodes would be in, osteoarthritis. You see them at the joints, the dips and the pips. Osteoarthritis spares the MCP joints, which are here. You guys can see my mouse cursor. And but you're right. Look at this finger here. I mean, this finger's massive compared to the other fingers. You always want to compare bilaterally, but it almost looks like one side has swelling and the other one doesn't. So this person, Agnello, is saying anti-CCP. Do you guys know what diagnosis? Agnello knows what diagnosis, but what diagnosis are we referring to for number 5? Anti-citrullonated peptide is anti-citrullonated protein antibodies. So CREST can have rheumatoid factor, but it wouldn't have anti-CCP. Anti-CCP is more specific to rheumatoid arthritis, right? Exactly, Agnello. Arthritis, rheumatoid. I assume that in Portuguese means rheumatoid arthritis, but I have to take your word for it. Unfortunately, I'm still studying, but I appreciate seeing it because now I can kind of try to understand it. Okay, I'm not even gonna try to pronounce it. You guys will make fun of me. But 35-year-old woman presents. I think you might be right already just from seeing the picture. But let's see. 35-year-old woman presents 4-month history of hand pain. Worse upon wakening in the morning. She reports that her pain improves throughout the morning. Dactylitis, he's saying. Marcia, yeah, improves throughout the morning. So both hands are equally affected. Findings from, that's important, physical examination are shown in figure A. Which of the following autoantibodies? So they're already telling you this is an autoimmune disorder, highly specific for the patient's disorder. So what is wrong with dactylitis? So you can get dactylitis, I think you can call it dactylitis in anticentromere. What is anticentromere? These are super high yield, you guys. And I know a lot of students wait until the end to learn all the antibodies because they're so annoying. So 5 is anti-citrullonated protein, and you're absolutely right. That's rheumatoid arthritis. What is 4? What is number 4? Anti-IgG antibodies. What are those called? Right? What is anti-centromere? Do you guys remember? Crest? All right, crest. And then, yeah, I think that's right. Anticentromere is crest. Diffuse scleroderma. Yeah, that would be crest. Yeah. And so antihistone, do you guys remember antihistone? That's drug-induced lupus. Yeah, lupus, but drug-induced. Exactly. And then anti-Smith. Do you guys remember anti-Smith? What is anti-Smith, you guys? Sjogren. So Sjogren will be Rho and La. So you'll be SSA Rho and SSB La. And I'm not going to tell you the Brazilian mnemonic for that, but it's inappropriate. But because somebody told me this, but Rho La is Sjogren. But anti-Smith is the most specific antibody for lupus. So you want to screen for lupus at first. You want to screen with ANA, right? It goes ANA, and if they're positive, then you do what? Anti-IgG. DNA, right? Double-stranded DNA, right? And if they're positive, you could even go further. You usually don't. And you do, if they're Smith positive, you are 100. You're like almost 100% sure that they have lupus. With ANA, it's super non-specific, but it's super sensitive. Are we all clear on the difference between sensitivity and specificity? Yeah. So I'm going to go with, he's waited patiently here. We're going to try his answer. He's absolutely right. So anti-CCP, but this is also in rheumatoid arthritis. The problem is it's not specific to rheumatoid arthritis, even though it's called rheumatoid factor. It's very it's unfortunate that it's called rheumatoid factor, basically, because although you will see it in most cases of rheumatoid arthritis, anti-CCP is more specific. Exactly, Agnello. That was great. Yeah, great job, you guys. So this is, I love this question that we got this question that we did well on it as well, because it's super instructive. Now, I just have to take a moment here and make sure that I'm not holding somebody up. So I'm just going to take 1 30-second period of time. Oh my God. Okay. All right. We're good. So 32-year-old farmer is as soon as I hear farmer, you guys, I'm already thinking about a certain type of answer choice. You guys can just tell me what answer choice I'm thinking of when I hear the word farmer. Do you know what I'm talking about? You might. Because I hear farmer and I think like there's like 3 diagnoses that I think of right away, but there's one that sticks out. We'll see if it is that thing. Farmer is brought to the emergency department with his wife. The patient was reported anxious, sweaty, complaining of headaches and chest tightness before losing consciousness en route to the hospital. Which of the following is mechanistically responsible for this patient's symptoms? Okay, so it is exactly the type of question and diagnosis that I thought it would be, just knowing that it was a farmer, and especially in the emergency department, and especially that he didn't bring himself to the emergency department. What kind of patient is a farmer that has anxiety, sweating, and complaining of headache and chest tightness? What do you guys think about that? Yes. Yeah, Marcia, exactly. I love that I'm learning Portuguese as I go. Organofosforados. Oh, God, don't make fun of me. No, Marcia, we're in Brazil, man. I'm in Brazil, by the way. You guys can speak Portuguese all you want. But I hope I'm not murdering the pronunciation. But you're exactly right. Organophosphates, right? And they're super fast acting, exactly. And so he's anxious. So what is the mnemonic that they use in first aid? Exactly, Sergio. Exactly. So anticholinergic. Yeah. So what is the mnemonic that they use? Exactly, Romulo. You'd use atropine for this. Yes. And so what is the mnemonic that they use on first aid? What is the mnemonic that they use for first aid? They use hot as a hair, dry as a bone. Exactly, Sergio. Yeah. So dry as a bone, mad as a mad hatter, crazy as a yeah, exactly. Yeah. So these are all the anti-muscarinic. These are their muscarinic effects, right? So if you're sweaty, that means you're dripping, right? You got fluids. There's fluids coming out of you. You're sweating, you're urinating, your nasal discharge, all the things that make you leak are the muscarinic things. Anti-muscarinic, like atropine would cause, would dry you up, right? Anti-muscarinic. So organophosphates, how do organophosphates cause toxicity? Do you guys know? So these crazy as a hatter, hot as hell, hot as a hair. These are anti-muscarinic effects, but we're talking about organophosphates. Are these muscarinic or anti-muscarinic effects? They're anticholinergic, right? So how do they work? Do they work on acetylcholinesterase, or do they work on the acetylcholine receptors themselves? They inhibit acetylcholinesterase. So this is going to be one of the last drawings I do here. But just to make it clear, I know you guys understand this already. I'm just going to make it super clear because when I'm teaching, I like to make sure that we have a sense. So this is a signaling baton, and this is a signaling baton of another cell. Acetylcholine release into the cleft. This is the worst drawing ever, but that's the only kind of drawing I can do, guys. ACH. Okay, so then there's this enzyme here, right? Acetylcholinesterase. And what is acetylcholinesterase's job? It's to go to the acetylcholine and destroy it, get rid of it in the cleft. So what happens when you get rid of the acetylcholinesterase? You get an increase in acetylcholine. Increase in acetylcholine activation. And that results in muscarinic effects, right? And that's organophosphate poisoning. What atropine will do, I shouldn't use blue to describe atropine. I should use a different color, but atropine comes in, and on these receptors that are receiving acetylcholine, atropine is going to block them. And when atropine blocks them, then acetylcholinesterase can increase the acetylcholine as much as it wants. It's not going to, I don't think it's a competitive inhibitor, Marcia. You can look that, let me know if I'm wrong, but I think it directly blocks the acetylcholine receptor. Am I wrong about that? Let me know. But tell me, seriously, guys, tell me if I'm wrong when I'm wrong so that everybody knows that I'm wrong. Sometimes I'm wrong. I'm not wrong very often, but I am wrong sometimes. But I think this receptor is directly blocked. I could be wrong. And when the acetylcholine concentration goes up, it still doesn't have an effect on the postsynaptic neuron and cause the toxicity. And so you'll give atropine, but you also give another drug, pramipexole, which is another drug that you can give. And Sketchy does a really good job of memorizing this as well. So which answer choice do we like, you guys? Or irreversible. Why irreversible? Do we think that it's irreversibly binding to the acetylcholinesterase or reversibly? It's irreversible. Leslie's exactly right. So it's just like we described in the picture. So pralidoxime is another drug. It's a very common drug that you would give. Pralidoxime reactivates the cholinesterase. So after you block the receptors, you want the acetylcholinesterase to work again, and pralidoxime will do that. So it's a nice association. You want to give atropine and pralidoxime at the same time. And I think it's the nicotinic and muscarinic. So the yeah. So I need to look at atropine, whether it's, I think it's a direct inhibitor, but that's a great thing, because that's another, Marcia, that's a great way that they could test us. They could be like, is this a competitive inhibitor, or is this a competitive agonist? What kind of drug is this? And we really actually do need to know that for step one. So shame on me for not knowing, but with certainty. But I'm pretty sure it's a direct inhibitor. Let me know. Reversible inhibition of acetylcholinesterase. Mechanical employed by medications include treatment of is given with albumin. Exactly. Exactly, Marcia. Yeah. So this is talking about donepezil, which is reversible. You know, I love the acetylcholine association with Alzheimer's. I think it's really fascinating. It also is what causes extrapyramidal side effects because dopamine actually inhibits the release of acetylcholine. And so when you use D2 blockers, you decrease your dopamine, you get increased acetylcholine, you get extrapyramidal side effects. But in Alzheimer's, you also get acetylcholine in your CSF will change as a result of acquiring Alzheimer's disease. Pyridostigmine is used for myasthenia gravis. Yeah, transiently worsening symptoms, exactly. Because you're blocking the receptor, but you're still going to have such a high concentration from the continuance of the organophosphate toxicity that you really need the acetylcholine esterases to get in there and get rid of that acetylcholine. And so you get rescued by the pralidoxime, so to speak. Guys, we are coming to the end. I just want to mention that that I'm going to be doing these every 2 weeks, and I'm so appreciative that you guys come here. I enjoy teaching so much. I get such a kick out of teaching for a little bit, and you guys have participated the whole 2 hours, which is stunning. Um, I just want to mention that I teach privately, USMLE preparation, and I'm the guy who's doing the training center for the USMLE here. So we have funding to do that. Thank you guys so much. Thank you, Sergio, for coming and for participating. You guys have been just a treat to meet and to talk to about some USMLE stuff. So let me know if you have questions about the exam and you want to get started with some resources and things. I have a lot of like really good test taking recommendations for you. I don't get rich teaching you guys. It's for my own edification and enjoyment of for teaching because thank you so much.